No. So our next presentation is very complementary with what Jessica was talking about. So I want to introduce, and I'll try to do this a little fast because I don't want you to lose some time. So this is Dr. Natalia Trehan.
Yes.
Trehan, good job. She's an assistant professor of oral medicine in the Department of Biomedical Sciences and Community Health here in the College of Dental Medicine at MUSC. And she's new faculty here, and we're really excited to have her. I'm just going to give you a couple backgrounds on her degree, and then we'll let you take it away. So she completed, she earned her dental degree from the Medical University of Lodz.
Łódź.
Poland. I'm just going to say Poland, which is a cool story. We won't talk about it now, but that's a great story. We heard it last night. And then she completed her chief residency in oral medicine at the University of Pennsylvania School of Dental Medicine. And then she came here to MUSC. And I'm going to let you just speak a moment on what your specializations are, just to allow you to get started. And you have 45 minutes-ish. So let her get into that presentation, and then we'll save for questions near the end, if that's okay, unless there's something you really misunderstand or need clarification.
All right. Thank you so much, Karen.
And test your mic.
Can you
guys hear her okay?
Is this okay? Or a little bit closer? A little bit better? Okay. I think that should work. I talk relatively loudly, so that should work even without the mic. Thank you so much for that introduction and for having me here today. So as Karen said, my name is Dr. Natalia Trehan. I am an oral medicine specialist. And so today my presentation is called Small Mouth, Big Impact, and how we're going to navigate oral health care in scleroderma. This? Perfect. I have no financial disclosures with any companies at this time. And these are some resources I like to use in general for my presentations. And there's some of the academies I'm also involved in. So one of the ones is the American Academy of Oral Medicine, which is my academy, and then also the American Academy of Orofacial Pain. So before we kind of get started, I'm going to explain what oral medicine is, because not many people are super familiar with this. So oral medicine, as I like to describe it, is the interconnection between medicine and dentistry. So it's that specialty of dentistry that represents the healthcare of medically complex patients, and it's the diagnosis and management of these medically related disorders or conditions that affect primarily the oral cavity, but also the whole head and neck. So that's what I focus on. And what I've done in the past, I've been very fortunate to speak at the American College of Rheumatology and other rheumatic-related conferences as well. So I had done a survey with one of the foundations I work with, and we had asked our patients, what does oral health mean to you? And as you can see, there are a lot of answers that sort of pop up. I don't know if my laser is working. It's just very tiny. But one of the main things was confidence, right? That's something that comes up a lot, the confidence of your oral health and that head and neck impact. The other is that equitable access to care. And that's something I'll talk about as well too. And then Jessica did a great job talking about insurance, so I'm not going to talk about that too much because she is the expert with that as well. But also taking care of dry mouth. And then another one that I really like, scary and important. And that's kind of what I want to focus on too, because for all of you, there's so much also going on in your bodies that sometimes it's very easy to let the dental go to the side, especially because it's different insurances. I know I said I'm not going to touch on insurance, but you have your dental benefits, and dental insurance is so much more complicated than just your medical benefits too. So that creates a whole host of problems as well. And so when I also ask patients, what are you doing already that you've had to do as adaptations or modifications that you've noticed after your diagnosis? So a big one that tends to come up is an electric toothbrush because it's sometimes just easier to hold and navigate with it. The other thing is decreasing sugar because we have less saliva in our body. So there's a little bit more of that dry mouth that comes, and you have a tendency to get a little bit more cavities. So unfortunately, you do have to decrease sugar. More dental appointments. They have to become more frequent because now your mouths might not open as much. So what previously happened, you could do a cleaning in one visit, now means that you have to go and break that up into multiple visits. You have to plan that out, and you might need to go more frequently because now you have more cavities or you're getting fungal infections. A night guard, so sometimes you might be clenching or grinding your teeth, so that night guard just helps. It doesn't stop you from clenching and grinding your teeth, which I want to make very clear, but it does help protect the tissues in the teeth that are there as well. And then lifestyle changes, and one that I love is the expensive products because, yes, as you know, you unfortunately get a lot of these stuff over the counter, and you just are adding to that bucket list of products that you have as well. And I wanted to briefly go over the head and neck features of scleroderma. So the way scleroderma knows, and I'm preaching to the choir, it's this fibrosis of your skin and connective tissue, right? And with the oral moisture, it's usually reduced. So one thing I like to compare it is sometimes with Sjogren's disease, because I tend to see a lot of those patients as well. So for Sjogren's disease, they have dryness because of the lymphocytes attacking their glands. But for a lot of you, you might have dryness just because of the reduction of saliva because of the fibrosis of your glands that is present. And then with salivary gland involvement, again, you're just getting an atrophy of the glands, and there's just this fibrosis that's present. So it's just not letting your glands work as they should be. And then you might get a little bit of parotid enlargement. So that's your glands right here where you get saliva production, and it may be a little bit enlarged, but that doesn't tend to happen too much with scleroderma. Again, that's a little bit more with our Sjogren's disease patients. And then you've probably all noticed the microstomia, that inability to open as much as you were able to previously because of the fibrosis that is present. Radiographically, and we'll go over all of these findings in a lot more depth as well, you might notice that your dentist says you have a widened PDL. And that basically means that that tooth, there's tissue around it, it's a periodontal ligament around it, it is now opened up. So we'll talk about examples over there. And also, Dr. Farrell did go over this, a little bit of that resorption that can happen. And one of the things is in your mandible that can resorb as well. And then there are oral hygiene challenges that sometimes, unfortunately, providers don't always take into account because we want that perfect oral health, and they'll always ask, have you flossed today? Have you brushed? But sometimes it's not possible to do that. It is challenging to do that. So I'm going to talk a little bit about modifications on how we can try to achieve that and make it a little bit more accessible. And then treatment focus. As dentists and as providers, we want to work on increasing that opening or making it comfortable with the opening that you have, and then the management of that fibrosis as well. And so with scleroderma and oral health, we do have that microstomia, as I said, and that you have kind of noticed. And we get what we call trismus. And trismus is the medical term for a limited opening. So in most patients, the normal opening tends to be 40 to 60 millimeters. That's between 2 to 3 fingers. So if I went like this, oh, that was my jaw clicking. Sorry, I have TMJ issues. I was not supposed to do that either. So it's a 3-finger opening that usually you're supposed to be able to open to. And with trismus, it means usually it's less than that 2-finger opening. It's 20 millimeters or even less than that. And then we also have our PDL widening on the x-rays that we'll talk about, or the periodontal ligament. And then you can have oral mucosal or gingival fibrosis. So you can have gingivitis, which is that gingival inflammation that's present. So you might notice, or your dentist might say, oh, your teeth seem a little bit more loose because of the fibrosis that's there. And then the temporomandibular disorders. So one example was that popping of my jaw that you heard very loud and clearly. But you can also get the resorption of the condyles that is present over there because you have that bony resorption. You can get muscle pains. You've been opening a certain way your entire life, and now your bite and the way you open is changing. So the way you're chewing and all of that is being modified. So you might be getting more pain. So you have myofascial pain now associated with that. And sometimes that jaw pain is triggered with migraines and headaches, and that's causing more pain too. And then, as I said, you can have resorption of the angle of the mandible, so the jawbone itself as well. And again, preaching to the choir, the barriers behind the clinic or beyond the clinic, right? the cost that's associated, because unfortunately dental doesn't always tend to be covered. And so one of the things I like to do is if my patients want it, I will write a medical necessity letter that they can provide to their insurance companies for their dental benefits. And some places will do medical benefits for dentistry, but for most cases it is dental benefits, and you can ask your provider for a medical necessity letter to get more visits covered as well, or any of the appliances that you need. And then you might require more frequent visits. So you're a little bit more immunocompromised, and it might be because of the medications that you're on as well. So the rule of mouth, or the rule of thumb, actually, sorry, it's a dentist euphemism right there. So the rule of thumb is that you go every 6 months, right? You've always heard that, oh, you should be seeing the dentist every 6 months. Unfortunately, for autoimmune disease patients, we recommend 3 to 4 times a year. So you should be going more frequently because your mouth is more dry. You're more likely to get cavities. You are taking medications that is compromising your oral health as well. And oral health is systemic health. Things that affect your mouth, unfortunately, can affect the rest of your body as well. So now you have to go more frequently. And then the lack of transportation to these visits as well, because it is hard to do that when you have so many other appointments also going on, and how to kind of handle that. And then the fatigue, just from the amount of appointments that you have to go to and the amount of things that you have to manage. And then if you're a dentist, luckily this is like our dental clinics are part of Epic and part of MUSC. And if you see your providers here, great, they have access to all your notes. But now you have to send your dental notes to your provider or vice versa. And that creates so many more challenges for you as a patient as well. And then competing medical priorities, which, as I said, unfortunately, dental health does tend to get left behind. And it's through no fault of your own. You have so much else going on. So one of the things that I wanted to also focus on is medications and oral health. And again, it was a great segue from Dr. Farrell's presentations, because I want to talk about more of the medications and what you can see. There are a ton of effects that can happen, but I'm going to focus and highlight on the most common ones as well. So what can happen is you can get lichenoid reactions, and that's sort of like a dermatitis or an allergic reaction that you can get from certain medications that you'll see inside of your mouth. You can also get ulcers from the medications that you're on. You can get erythema multiforme, which is another disease that you can get in your on your skin as well in your mouth. You can get hyperpigmentation. You can get autoimmune diseases secondary to the medications as well. You can get infections because of the medications you're on. And then you can also have more dry mouth because of the medications and having that side effect. So one of them that I wanted to focus on is just biologics and oral health. And so some of these disease modifying medications can cause you to get ulcers inside of your mouth. And this is where it becomes a conversation between you, your rheumatologist, and sometimes your oral medicine provider too. And it's what the priority is for you. So this patient had psoriatic arthritis, was on multiple medications, failed multiple medications, and finally was on a medication that worked. And it was working great for this patient. But then they started getting ulcers in their mouth. And they started getting this lichenoid-like reaction in their mouth. And so the conversation became, is this something that you can manage and we deal with palliatively? We give you tools if there's any pain. We give you mouthwashes. We make sure that nothing's going on. And you continue on this medication because it's working for the rest of the body. Or do you want to stop the medication and then we can see if that works for your mouth? In this case, this patient said, this medication works. I've tried so many, nothing else works. So I'm just going to continue with the medication when they were in conversation with the rheumatologist, and we'll just manage the mouth effects. If it gets worse or it's going to cause any harm to my mouth, or it might lead to like a precancer or cancer, then let's consider at that time. But for now, it's manageable. I'm going to continue that. And I've had patients who chose the opposite, who were like, this is so painful. I cannot deal with this. I am stopping the medication. We stopped it. The lesions disappeared. And then they had to trial other medications too. But unfortunately, that is a personal conversation with you and your rheumatologist and what the priorities for your care are too. And what also can happen is sometimes with Plaquenil, so hydroxychloroquine, is you can get this drug-related discoloration. And it tends to happen on the palate, so right on the roof of your mouth that you can see. And it's like this bluish gray discoloration that can happen. That's around 44% of the lesions that are blue-gray. And it usually just lasts during the time of treatment. So when you're on the hydroxychloroquine, you'll notice the pigment. It doesn't cause any harm. We just notice that there, and we keep an eye on it. And then when you say you get taken off of it, it usually does subside from there as well. And one of the things the dentist might ask is if you have any amalgam fillings, because sometimes amalgam fillings, the silver fillings, they look the same as well. So they'll ask you if you have any amalgam fillings or silver fillings, which this patient does have over here. But it's not really over here, it's more in the palate. So this made more sense that it was from their Plaquenil instead of just the amalgam kind of spreading when they removed it. And then you can have decreased salivary flow. So this is a patient as well. They did have secondary Sjogren's. So this was a more severe case of secondary Sjogren's, and it has scleroderma as well. So they had more of the Sjogren's side effects with the dryness that was present. And so this patient, again, what can happen is you can have the cavities because the saliva acts as a protective barrier. When that protective barrier is gone, unfortunately, there's nothing really holding back the bacteria and the cavities in your mouth. So one of the things we kind of discussed yesterday is not every dentist will tell you this, but when you eat something, you should not be brushing your teeth right away. You want to wait 30 minutes after you eat something to then brush your teeth. You can rinse your mouth with water right away, and that's fine. And the reason you want to do that is because when you brush right after, you are basically eroding away the enamel and that on your tooth layers because it's too acidic. So you want to wait 30 minutes. You can rinse with water completely fine to take away the sugars or whatever you've had. And then 30 minutes later, if you need to brush, that's when you want to brush as well. But again, this is something that's not really commonly discussed, but it is important to know, especially when you are at a higher risk of developing these cavities. Yes. So basically what happens is you have different layers in your teeth. You have your enamel and then your dentin and then the root, the nerve inside, if any of you have gotten root canals. So the outside layer, if you brush right away, the mouth is still very acidic. So basically what happens is you're taking away the layer of the enamel and you will expose the dentin, the middle part of your tooth, more frequently. So that's why you want to wait when you're brushing. And then you can get more frequent trauma as well with this as well. And it does affect your speech, your swallowing also, and then overall your quality of life, right? Because this is the part of our body we tend to use so frequently, and people don't realize how much of an impact it makes when you lose access to it or it's not the same as it was before. And so we have looked at different kind of metrics in general. There are a lot of studies about this as well, about just going to the dentist as well. So many patients, as you assume, relate oral health with their quality of life. Because now, if you can no longer chew as well or eat the same foods that you were used to, if you can no longer swallow or talk every single day, if you no longer can drink or have those conversations, or even when you're yawning, it now hurts to yawn, that overall does play an impact on your quality of life. And then the challenges with completing oral hygiene, right? So instead of something that should be 2 or 3 minutes, the ABCs, and you brush your teeth, can now take up to 45 minutes to an hour to get to that task because you're not able to hold the manual toothbrush or use that kind of dexterity anymore. And then if you have flare-ups, this is not a priority on that day, which is reasonable. So you kind of will skip that too. And then it also depends that you might be on multiple different tools. If you have challenges between the teeth, you might be using like an interproximal brush if you can't use floss and move that around. You might have to, some days, use like an electric toothbrush, but some days it's not possible to use an electric toothbrush. You have to try something else. So that also then adds up with the cost perspective. And the previous experience shapes the attitude, right? And unfortunately, in my career, I will always get, oh, I hate going to the dentist. And I always say, I'm not that kind of dentist, so you're good. So that's one of the careers that's one of the healthcare professionals you'll always say, oh, I hate them. And then but unfortunately, that shapes your experience. The second you say you hate the dentist, that fear makes you step back. And I have so many patients that haven't seen a dentist in decades because that has shaped their experience because there are comments made, or they feel uncomfortable with them, or they think that they don't know the medications that they're on, or they don't understand the disease or want to deal with something a little bit more medically complex. And that completely shapes how you're going to treat your oral health as well. So I think it's very important to have those discussions with your dentist. Or also, if that dentist is not working out, it's completely fine to find another. I sometimes do recommend dental schools because it's a great way, one, to teach students when they're there, when you're coming in as patients, so that they can go, when they go into their practices, they'll have informed care and they will know how to manage more medically complex patients. And they will not have any of these biases that unfortunately some providers do. So dental schools are really great, and the students are always up to date with the literature. They're having to learn at the guidelines as well. So that tends to be a little better. It does take longer in a dental school. So that is one of the caveats. I will warn you, they are learning, but they are under the supervision of the attendings. And so one thing I wanted to start doing, we've talked a lot about what's going on, but now I wanted to start giving you some suggestions that you can implement. So for the topical management of dryness, there are so many sprays and drops, gels, lozenges, mouthwashes out there. And a lot of them are over the counter, but we do have some prescription ones as well. And then you can also do artificial saliva. So artificial saliva is not something I recommend right away, and I've tried it before. It's just very gross feeling inside your mouth. So it's something that you want to fail everything else, and then you're like, okay, I'm going to try that artificial saliva. So it has water, it has some electrolytes, including like sodium, potassium, and calcium. It has the mucin that gives you that like saliva-like sensation. And then it also has some enzymes in them. And then antimicrobial properties, right? Because it needs that barrier that you don't have your normal saliva for. So some of the over-the-mouth products that you can do Xerostome, which is one of the ones that's very known. There is gum, hydrol, spray, and gel. Act is one of the famous ones, same with like Biotene dry mouth products. Those are very well known. One other one that I really like, and a lot of my patients like too, is Xylamelts. So Xylamelts are a little sticky lozenge that you stick right onto your gums on the inside, and you can keep them overnight, and they will release saliva overnight for you to help. And so it's not as useful during the day because if you're talking, it's going to slip in your mouth. But if you're sleeping overnight, it tends to help with saliva production. So that's one a lot of my patients swear by. And then there are other ones too. Like I mentioned, Biotene, I have patients who carry their bottle with me, that little spray bottle, everywhere they go, and they will just be spraying with that as well. And then I always recommend sugarless candy drops. So you want the sugar-free ones because we don't want to introduce more sugar, unfortunately, into your bodies. And there are a lot of different ones too. If you are diabetic and you want like a sweet treat at the end of the day, something I'm a huge proponent of, they can all testify at dinner yesterday. Basic Bites is a great kind of sugar-free, diabetic-friendly, and saliva-friendly product. So it's like a little caramel, and it comes either as a caramel or a chocolate flavor. And it's a little chewy. You put it in your mouth, and it releases saliva. And it is sugar-free too, but it releases saliva right away. And it's like a little candy or treat that you can have at the end of the night as well. And then there are sugar-free breath mints that you can do as well. Supplements that you can take, and I really wanted to talk about these two, is vitamin E soft gels and omega-3 fatty acids. So we talked a little bit about the bisphosphonates earlier, and one of the things as dentists, if you do have to get like dental work and or dental treatment and you are on a bisphosphonate or in that period, we recommend things like vitamin A, vitamin E, while you're doing that because that helps overall. But the way that you do vitamin E for dry mouth is a little bit different. You're not going to be swallowing this as a medication. Instead, you're going to be opening the soft capsule and putting it in the water and swishing around with it. And that vitamin E as a topical agent can help sometimes with saliva stimulation as well. The omega-3 fatty acid, overall, there's some studies, but it's a lot more anecdotal, so a lot more stories of patient examples that taking omega-3 can help with the saliva as well. And then some more at-home recommendations. So I do recommend increasing the fluoride if you haven't done so already. And that can be going in your dentist's office and doing in-office fluoride trays. And it can also be doing high fluoride products at home. So something I recommend is Prevident, and it's a prescription toothpaste. I will give my patient 11 refills because there's no point coming every single time for me because you need more toothpaste. So you get 11 refills. There's a mint flavor and there's a berry flavor. So if your mouth is so dry that high flavor products are bothering them, I recommend getting off those high flavored products. Stop the acidic products, stop the mint, and do something that's a little bit more like watermelon, like children's toothpaste, or berry, or the baking soda toothpaste. And that doesn't mean you can use the Arm& Hammer baking soda toothpaste, but you can also just use straight baking soda for a little period of time if the burning is bothering you from high flavored products. And then you go back to a little bit more of a gentle toothpaste as well. I also recommend a humidifier in the bedroom. So it's a warm humidifier between 40 to 50%, especially when the air is dry. And that can help overall with the fluids in your body and increasing that as well. And then keeping water within reach. So ideally, you're drinking water in a few sips a day and not just chugging it once. We want you to drink just a little bit, but you can also suck on ice. And ice is one of great things, even though as a dentist, I should say, don't chew on ice, even though I do, but don't chew on the ice. You're just sucking on it because the amount of time it takes for that ice to melt, your entire mouth is coated and it's going to last longer than just that few sips of water did. So you can do both, but sometimes the ice is just a little bit more helpful as well. And soft bristle toothbrushes like a children's toothbrush can help as well. So these are some of the modifications I have recommended for patients. So one of the things that you can do, and I have it on the other page, is sometimes the pencil grip that you can use for pencils, you can use it on your toothbrush itself. So you don't have to hold it as fine of a control. So it gets a bigger grip on it, or you can put putty around it, and the putty will give you a more solid grip to hold onto it. The other way is using a little bit of a band around the toothpaste. It's not the most ideal solution, so sometimes the putty is a little bit more helpful. Oh, I thought I had one more, but the other options are with the interproximal brushes. So sometimes floss is not as easy to maneuver. So there are floss picks of different lengths that sometimes can be used. And again, you can wrap the putty around the handle as well. So it's a little bit thicker of a grip to hold on to compared to just the regular floss strips. And then some of my patients have asked about water picks as well. Water picks are great if you are using them. If you find that it's easy to maneuver and you find it's something that you want to implement in your life, please go ahead with it. Okay, and then some additional recommendations. So I talked about the humidifier as well. What I want to talk about a little is salivary gland massages. And this was a recommendation by the Sjogren's Foundation. They've actually come out with this sheet, and you can go on their website as well and see this. But basically what you're doing is you're massaging your glands. And you have 3 different glands in your head and neck for your saliva glands. You have your parotid glands right here, and then you have your submandibular right under, and then your sublingual glands. And the parotid glands sort of end midway to your cheek. So this is your parotid and it ends midpoint. So that's where it opens. So basically you're taking 2 fingers and you're massaging it down. The question I do get from some of my patients is, okay, is it now going to make my skin kind of sag forward? And I'm like, unfortunately, yes, if you're doing it that frequently. So just gua sha it the other way back. And then you can make up for that. And then you can do the submandibular and sublingual glands. So again, you have your glands here, and they open right at the front. So you're taking 2 fingers and you're just pushing it down. And you can do this multiple times a day. You just push with firm fingers all the way down. I do recommend one side at a time because you have a lot of venous structures over here. Better safe than sorry. I don't think you're going to pass out from doing this, but we want to be cautious. And you do it a few times on each side, and you do it a few times a day as well. And you can do this before you sit down for a meal or after you brush because you want saliva at those times. So sometimes that can be helpful as well. And with dry mouth, you can also get a little bit more of yeast infections. We all have a baseline level of yeast in our mouth. sometimes that yeast can be a little bit more activated if you are on antibiotics, if you are a little bit more stressed, or if you don't have enough saliva in your mouth. So getting checks of the yeast in your mouth, or basically if you have symptoms like a change in taste or metallic taste in your mouth, or you're noticing like some white patches with a burning sensation, or a coated tongue with some burning, then you can talk to your dentist and they can give you some and anti-yeast medication as well. And then doing the fluoride in the dental office, which is the fluoride trays or some kind of varnish, that little paintbrush that they put all over and then you can't eat for 30 minutes after. That's pretty good too. And some of the emerging and sort of complementary therapies. So these are things that don't really have a lot of studies about them. However, again, my patients have recommended and they do notice benefit with it. So I wanted to talk to you a little bit about this too. So one of the things is oil pulling. And I know that's kind of come up in the media sort of like a decade ago, where everyone was taking coconut oil, trying to pull in their mouth and see if it would whiten their teeth. Can I guarantee whiteness of your teeth? No. But I can say that it does sometimes soothe your mouth in terms of any burning sensation or discomfort in your mouth. And it can also sometimes help with the saliva. And you basically take 1/4 tablespoon of either coconut oil or a neutral oil like sesame oil, and you swish it around in your mouth, and then you spit it out. If you're doing coconut oil, please spit it out in a bag. Do not spit it out in your sink. It's going to clog it. I'm a dentist, not a plumber, and I cannot pay those bills. So I definitely make that caveat that you have to spit in a bag, throw that bag out. And you can make up your way from starting from 30 seconds to up to 19 minutes. I have a patient at 15 minutes that does this multiple times a day, and they enjoy it, and it really helps soothe their mouth as well. You can also get over here what looks like an Invisalign tray, but is not. It is a soft tray. So there are studies that show if you put something in your mouth, that actually will increase your saliva because it tricks your brain into increasing it. So sometimes that's why when the dentist puts things inside, you start salivating even more and they're like, oh my God, what are you doing? Never happens any other time. But with this soft tray, you can get this made. And this soft tray goes in your mouth and it tricks your brain into thinking something's there, which it is. And then more saliva gets produced as well. And then the last thing that you can do is drinking green tea. And this can be either drinking green tea, and it can be with a little bit of honey, because I know not everyone loves the taste of green tea, or trying green tea lozenges that are sugar-free. And so green tea contains something called polyphenols. And those polyphenols actually have shown benefit in both human and animal studies to increase saliva as well. So green tea is definitely great. It is green tea. It's not black or any other of the teas. It's the green tea. Okay, and then the other thing is acupuncture. So acupuncture, there are small studies that show that it actually activates the brain's regions that help control saliva as well and stimulate that saliva production. So I have patients who go because it's relatively low cost as well. It tends to have few side effects as well. And for them, they note that they have an increase in saliva. However, I will note that larger studies do need to be done on the actual benefits of it. Right now, it's a lot more anecdotal that my patients have said that it helps them overall, and they've incorporated it also for stress management. And then we actually use acupressure points in dentistry. So this is a root canal file if you've ever gotten a root canal, and we put it right over here in the foramen. So if you have a gag reflex and your dentist has never mentioned that before, you can put it right over there in the mentolabial fold and it will stop your gag reflex. Do not do this at home, please. You can do it at the dental office. So it helps to stop it. So if you need to get any impressions or anything done and you're gagging, ask your dentist to just put it right there. And then you can get orofacial pain in general as well. There are a lot of different causes for orofacial pain. It can be trauma, jaw abnormalities, it can be bruxism, which is like the clenching and grinding habits, and then even an enlargement of your parotid glands. And then you can have this, which is that example of the condyle. So the condyle is if you put your fingers right in front of your ears and it's that hard, the bony part that's kind of jutting out, and you open and close your mouth, you can feel it moving. That's the condyle. So sometimes that can resorb. So we say that it looks like it's beaking because it looks like a bird's beak, and that can cause some pain as well, and it can limit your mouth opening. So things that you can do in office mostly is getting trigger point injections. So injections that go in to target the muscle knots, and you can get them with dental anesthetic or with Botox injections. You can get things like muscle relaxants or using like a lidocaine gel to massage the muscle itself to reduce the muscle pain. If you have a clenching and grinding habit, I sometimes send patients for cognitive behavioral therapy. So that's not talk therapy, but it basically sees why are you doing this clenching or grinding habit and how do we stop it? And then also physical therapy for the jaw. So we have a lot of great physical therapists here, and there's some in other locations as well who focus on head and neck physical therapy and TMJ physical therapy. And they'll do a lot of like these manual manipulations and releases to help you with your muscle pain or jaw pain. And then things that you can do at home. So you want to limit it. So less than that, yes. Mhm. I will talk about that very briefly. Yeah. So you want to limit jaw opening. So you want to do for it might be less than that 2 finger opening, avoiding any of the hard, crunchy, chewy products that kind of makes it worse. Modifying your sleep position, so being on your back rather than your side and your stomach. Monitoring your posture, and then resting your jaw as well. And then easier said than done, stress reduction techniques, right? Because that does cause our body to just clench up in general, and our jaw unfortunately gets the brunt of it. And then massaging, especially with something like a Voltaren gel or lidocaine gel, where you massage that over extra orally as well. And so these are what you would get basically for the injections. So it looks like the little TB needle. And ideally, we do lidocaine without any epinephrine. That's what you get in your dental office as well. And it's very similar to acupuncture or dry needling, where we're going in, finding the muscle knots, and then breaking it up. I have patients come in weekly, and there's no side effects from this. The main side effect is just any needle that you or injection. If you're even getting blood drawn, there's always a risk of bleeding, bruising, or numbness that can occur. But the actual anesthetic is relatively harmless, and they get it to just relax their muscle knots as well. For Botox, that's a little bit different. So Botox is a neurotoxin that sort of relaxes the muscle. And with that, you get it once every 3 months. And we've talked about the FDA and non-FDA approved sort of mechanisms. So the FDA approves migraines, but things like the dystonias that you might have or muscle pain, those are non-FDA approved, but we do go forward with insurance for them. And these are the uses, again, like I said, for Botox that we kind of go for, and a lot of them are off-label. And we basically go in, inject into the knot, and it relaxes that muscle after that. The things that we also use in general for patients in terms of dry mouth is to standardize it, we use a lot of questionnaires. So there are a lot of questionnaires out there that have been made. There's no specific one that everyone uses, but there are ones that your provider might use to be able to see how are you progressing with your dry mouth or the other side effects that you're having, and how are we monitoring that as well. And this is just an example of one of the salivary problem impact tests. And this is one that you as a patient would complete and give to your provider to just kind of, so that both of you are on the same page in general. And these are the sort of referred points. So if you complain of something like headaches or migraines, sometimes it can come from your jaw or your neck in general. And these are just all the points that it can come from, as you can see. Okay. And you can do injections inside and outside your mouth. That's what we tend to do. This was me just going over them, but I see I'm a little bit short of time. So I just wanted to end with that periodontal ligament widening. So with that periodontal ligament widening in general, this is what you will see. I'll just use this mouse. But basically around that tooth, you just notice a little bit of a loosening of this ligament. This is what kind of holds the tooth in place. And with that, you can sometimes notice a little bit of loose teeth that are present as well. And so there are a lot of different options that we can consider, not as much for intraorally for the loose teeth, other than splinting them in place. But overall, things that have been considered in terms of the microstomia, which is that limited opening, There are a lot of studies that are coming out recently. They're not all large studies. There are a lot smaller, more case studies and case series that are there that have talked about a lot of these different therapies. And that can be like fractional lasers, hyaluronic acid fillers, the Botox as well that I've talked about, doing physical therapy and facial exercises, and then even using vitamin E as well. And they use another score to basically check the progression of that in general. And so when you do hyaluronic acid fillers, basically, this is something that Dr. Hashemi, if any of you see her in dermatology, does. So I will send patients over to her. We all send patients over to her. And she will use hyaluronic acid to help in terms of improving the opening that you have with your mouth. And there are patients who report benefits with this because it relaxes the mouth. It sort of increases the volume that's present over there and allows you to have a greater opening as well. So she's in dermatology here and she does a lot of these cases as well. And there are studies that show improvement using something like hyaluronic acid filler. I'm going to skip a little. The other thing you can do is doing like IPL laser, which can be helpful as well. And this is another type of laser, but like I said, there are not a lot of studies about this in general. And this is the last type of laser, which is a fractional carbon dioxide laser. And again, really not many studies, but patients have reported improvement of their opening in general by doing something like a fractional carbon dioxide laser. So basically, it improves the amount of opening as well as the fibrosis that was present for them as well. And I wanted to end on this slide, which is the considerations for the dentist. So when you're talking to your dentist and things that I recommend to other dentists as well, is for them to work with social services and insurance. And that can be including things like transportation to and from the dental office. It can be that medical necessity letter that I mentioned for your insurance providers for more frequent visits or any kind of tools that you might need. Telling them to schedule short midday visits if you need to break up your appointments into multiple visits. Using a bite block or having breaks during the appointment, or making sure your positioning is supportive. So if you need another pillow behind you or anything else, definitely bring that and talk to them about it as well. And then if you need to pre-medicate, if that's a muscle relaxant or any pain medications or topical gel beforehand for you to be able to tolerate that appointment, that's completely okay. And then after, you can do the self-massages and the use of heat and ice. And then these are just some more of the oral care tools. Oh, you can't see the sign, but it's just basically showing how we need to all work as a team in order to provide you with the best care. Thank you.